Beyond Practice, Fostering Diverse Partnerships for Successful Care Coordination. This webinar series is presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau of the Health Resources and Services Administration. My name is Barbara Wirth, and I'm a program manager at the National Academy for State Health Policy, also known as NCMHI, a nonprofit, nonpartisan forum helping states achieve excellence in health policy. NCMHI is fortunate to be collaborating with the National Center for Medical Home Implementation to advance the medical home model in state Medicaid and children's health insurance programs, and I'm very happy to be serving as your moderator for today's call. Before today's speakers begin, I'd like to share with you a few things about the webinar functionality. The slides will appear in the central window of your screen and will advance automatically. The National Center and webinar faculty encourage you to ask questions throughout the presentation using the question box window on the right-hand side of your screen. These questions will be answered at the end of the presentation. If the webinar faculty do not have the time to answer your questions during the webinar, the National Center staff will send you an answer directly via email at a later time. This webinar will also be recorded and archived on the National Center for Medical Home Implementation website. After the webinar, you receive an email with a link to the webinar evaluation. The National Center encourages you to complete this evaluation so that it can continue to improve the content and manner of its presentations in the future. This webinar is the second offering in the 2015 series, Pediatric Care Coordination, Beyond Policy, Practice, and Implementation. When the series was developed, there was every effort made to present care coordination in a very practical way, moving beyond simply the idea that care coordination was the right thing to do. The National Center wanted to show examples of real practices providing real care coordination, programs that, through fostering partnerships, have made care coordination work in their communities, and the importance of recognizing the value and measuring positive impact. If you've missed the first webinar or want to register for the final webinar, that information will be provided at the end of the session today. It's important to note that work in the field of pediatric care coordination, including this webinar series, is often guided and enhanced by the 2014 American Academy of Pediatrics Policy Statement on Care Coordination. This document gives practical guidance and provides multiple resources. And you'll notice, too, that the patient and family here are front and center in this policy. It's well known that the team is what makes care coordination successful and sustainable, particularly for those children and youth with special health care needs, and that families are the key members of the team and may themselves have had significant experience as care coordinators themselves. That is why the family partnership perspective is also a key component of this webinar series. This slide is often a favorite of many pediatric medical home professionals because it shows the complexity, if not the craziness, of the coordination that's required around a child and a family. And this coordination may even be more complex when one realizes that many of these different services and supports provided here need to actually coordinate with one another. It also shows the ordered chaos that care coordination can represent for many families. And regardless of this, at the center remains the child and his or her family. The National Center thanks Ms. Kristen Lynn for this graphic, and you'll note her web address on the slide. Here, we'll take a moment and you can see the objectives for today's webinar. So I'm honored now to introduce you to the first of today's speakers. Marian Earls is the Director of Pediatric Programs for Community Care of North Carolina and the lead on the North Carolina CHIPRA Quality Demonstration Grant. She has many years of experience as faculty on quality improvement learning collaboratives for pediatric primary care. Dr. Earls is a leader on many initiatives of the American Academy of Pediatrics focusing on quality improvement, early childhood issues, developmental and behavioral pediatrics, mental health, and bright futures. Today, Dr. Earls will share her experience with systems building specific to care coordination, noting the importance of and the strategies for fostering partnerships. So I'd like to turn it over now to you, Dr. Earls.
Thank you, Barbara. I'm really pleased to be able to share some of this information today, and I'm really interested in the questions that people will have. So we can do the next slide. These are my disclosures. I have pediatric friends who, when they do this talk, say, I'm a pediatrician, how could I have a relevant financial relationship? Okay, next slide. So we are all familiar with the 7 C's of medical home as the AAP has defined medical home, and I think today's discussion, while it includes all of these concepts, is really focusing around the ask for the medical home to be comprehensive and to be well coordinated. And I put an asterisk next to those because what I've realized in doing quality improvement work with practices is that a primary care clinician cannot do this by themselves, and because the systems work is a heavy lift. So how can we, in various structures, whether it's an AAP chapter or a state Medicaid organization or something like that, help primary care docs really be able to do that heavy lift, as I've indicated here. Next slide. So I just wanted to outline some of the key components that I'm going to be talking today in terms of systems building or making the heavy lift a lighter lift. And what's been key for us here in North Carolina in helping medical homes, not only with pediatricians but also family physicians who serve children, is we've used the Community Care of North Carolina infrastructure, and I'll say a couple more things about that as we move along. We've really engaged community and state level folks in standardizing communication. Another big feature of practices being able to effectively work with other community and state resources is that they have a way to communicate that's fairly standardized and predictable. We've leveraged key partners to help us facilitate the removal of barriers. If anybody has worked with practices before, they know that sometimes there are administrative and policy barriers that have just been around for a long time. No one's really addressed them, and it makes it very difficult to do the medical home work. So we've worked with our chapters of family medicine and pediatrics, with our Part C, our early intervention folks, with the school system, with Medicaid, with our mental health partners. And a big piece of the community care model is that we have care managers who are really functioning as liaisons between these community resources and primary care clinicians, and are very much a member of the patient or family-centered team at the practice level, even when they're not necessarily embedded in the practice. Next slide. So very quickly, just to give you an idea about Community Care of North Carolina, we are not really very typical for Medicaid delivery systems around the country. And so CCNC is North Carolina's Medicaid managed care approach. We have 1,800 primary care practices that are part of this, so we cover the entire state, and we're very much a physician-driven program. And you can see we have pediatricians, family medicine, internal medicine. A great percentage of our patients are children, which makes sense. We take care of the Medicaid and CHIP children. And we have 14 regional networks. Next slide. Which you can see here. This slide is not for memorizing, just to give you a gestalt. So we have 14 networks, and we have 100 counties in the state. And each of these networks participates in all of the quality initiatives, but they have a very local flavor. Next slide. So at these networks, there are primary care managers, behavioral care managers, and you can see the number of folks there, care managers for OB. There's network psychiatrists and pharmacists, nutritional folks, and transition nurses. And all of these folks are working at the community level for population health. And in that process, they work very closely with the primary care practices. And a key feature of their work is that they can enhance the medical home family or patient-centered team by being a liaison or help with care coordination beyond the four walls of a practice. Each network also has a quality improvement and practice support team with trained quality improvement folks who really help practices implement some of the quality initiatives. We share data with the networks and the practices quarterly, and that helps drive quality and so that those practice support folks can help practices improve their performance. And we have a multitude of quality initiatives, both adult and pediatric. Next slide. So specific to pediatrics, each network has a pediatric team. I won't belabor the list here, but you can see that there are care managers and QI specialists. There's generally a pediatric champion. There's care management specific for 0 to 5-year-olds. We have other folks that help with EPSDT and getting kids in for well child care. And that team is available at various levels to folks that are in practices. And so practices can come to the network and say they really want some help with quality, but the network also reaches out to practices to help them with their quality. Next slide. And again, this is kind of a long list here of the various initiatives that we've done in CCNC Pediatrics. But what we've really focused on is a population approach. And when we're asking practices as medical homes to step up to the plate on all of these various initiatives, we bring together some of their staff from the network as well as the practice team. So if you've done QI before, if you're asking a practice to do a QI project, they usually start a QI team. Maybe they have the physician and a nurse or a front office person. Well, we're doing that at the macro level in helping getting network people to work with practice folks to coordinate this work. Next slide. And this slide is our attempt to try to put together what it is we're trying to do. So on the right, in our lovely circles, you can see we've done a lot around EPSDT, mental health integration, and then children and youth with special health care needs. Those are our quality initiatives. On the left are what we call our underlying pillars. And if you see in there, there's all that work about practice support, care managers, population management, and those teams. Again, those are the folks that help the practices with that, quote, heavy lift to do the things that are on the right side of that slide. Okay, next slide. So the pediatric team, in my mind, enhances the reach of the medical home. So if I'm seeing a patient, and if it's as simple as a child with an ear infection that I'm writing a prescription for, I need to know where is, does this family have transportation? Does this family have access to getting to a pharmacy? Do they have appropriate refrigeration? All of those sorts of things that are outside of my reach when someone leaves my practice, I have folks to help me with enhance that reach. So at the state level, we have a team here. I lead the team here, and we try to hear from practices and networks what the issues are and see if we can facilitate relationships. But at the practice and network level, our QI and practice support folks also do this at the more local community level. So they provide data, they convene meetings, and we'll talk a little bit more about that, but they'll often bring referral folks to the table to help the practices in their network. The care managers participate in all of our practice training so that they can be aware of what the medical home is trying to do and then can align their activities. And they also help facilitate and track referrals. We'll do home visits for the practice, etc. Next slide. So in order to sustain change, so we're working with practices on these initiatives, we know that they need a new kind of communication with the community. Many practices, I'll visit practices and providers don't even know what are the resources in their community, for instance, for young children who need developmental services or for an adolescent who needs mental health services. So we really are working on helping practices build relationships with their key partners, help them network, and figure out how to exchange information in a way that fits practice flow and that enhances the care they're able to give families. Okay, next slide. So I'm just going to give you some examples of how this, how we support this new kind of community relationship, and then once some of this initial support happens, at the local community level, practices are able to maintain. So we've had a lot of community mixers. So around our mental health integration project, in some communities, we just simply brought together the primary care clinicians and mental health professionals so they could talk about how they want to relate to each other, how they want to send referrals, et cetera. For oral health, we've been really promoting getting kids to a dental home by age 1, as Bright Futures recommends. And so we brought together primary care clinicians and local dentists. Those are folks that don't usually hang out together, and we've had some really excellent ability now to get kids referred and in to see the dentist. Next slide. Another piece has been to help align goals and get some standardization done. So in foster care, people are aware of the AAP's guidelines for enhanced care of kids who are in foster care, particularly around their social emotional development. But what we heard over and over again was practices just couldn't, with every child, deal with all of the issues around exchange of information with child welfare, et cetera, et cetera. So at the network level, we brought together our local departments of social services, that's our child welfare agency, our care managers from community care, and then the primary care practices who were seeing most of those kids. And we've called it our three-legged stool, and they're working on standardizing ways that they communicate at the community level. Similarly, with our sickle cell project, we were able to link our care managers with public health sickle cell educator counselors around the state to help identify patients with sickle cell, particularly folks who have not been getting regular primary care. And then around ADHD, when we did our training with the practice teams, we brought lead psychologists from their local school systems so they could collaborate on how they were going to communicate. Next slide. And what some of this alignment has led to is ways of getting standardized communication, referral, and feedback. So in our Assuring Better Child Health and Development project that we've done with NASHP and Commonwealth Fund, we're 15 years into this project. We have built consensus between our preschool school system, our early intervention program, and practices for standard ways to make a referral, have exchange of information, a two-way release of information, and a standardized feedback form. People tell me this is miraculous. It's not rocket science, but it did take a long time. But standardizing that has made it so much easier for practices to make referrals and find out if kids got to the services that they needed to get to. Oral health, similarly, we've got a standardized oral health screening tool based on the Bright Future screening tool that also has a referral aspect to it. So it can be sent to the dentist, and the dentist can fax it back to the practice to let them know if the kid has gotten in. So standardizing those things has made a huge difference in the kinds of things we were trying to push from medical home. Next slide. Two more examples. Our Fostering Health North Carolina, we've been able to develop consensus with child welfare on visit forms, and we've also given the social workers at our child welfare agencies access to our informatics center where they can look up patients and actually look at some of their medical history when they're first taking those kids into care so that they can identify any unknown medical needs quickly. With our sickle cell project, we've developed co-management guidelines with the hematology specialists from around the state so that there's clear expectations on where the primary care physician's role stops and how they relate to the specialist. Next slide. And then finally, we've been looking at ways to try to hardwire these systems So we're doing a lot of work on pediatric electronic health record. We've did one of 2 states in CHIPRA to be able to work on the pediatric EHR format. And we're putting a big emphasis on helping practices utilize a referral tracking and feedback aspect to their EHR, and also giving vendor guidance to help facilitate what practices are trying to do in this area. And we've, as I mentioned, developed partners to help carry projects forward and also help with some of that heavy lift. So both of our chapters of the pediatrics and family medicine work with us on multiple maintenance of certification Part 4 activities. We have 5 activities that we've developed. And the Pediatric Society is carrying on and has received grant funding to carry on our Fostering Health North Carolina project. Next slide. So a few pearls. I think I've mentioned these things several times, but the fact that we've linked primary care clinicians very closely with their care managers and had them work together whenever we do a quality of project has made a huge difference. We've had work groups where we've pulled from our primary care clinicians and care managers to come together to develop some of these materials so that they can work together on, on the topics that you see there. And next slide. We've had ongoing forums with folks that are at the practice level to give us reality checks. So with our ABCD project, we have a quality improvement group. These are folks that are in the practices that can come to us and say, hey, this isn't working. We need some help with some of these policy barriers. And we've had a pediatric work group that brings physicians and care managers together around these issues. And finally, as I mentioned, we've had these standardized processes for communication, which is really huge, particularly in the area of mental health, so that folks can coordinate the care of their patients. And thank you.
Thank you. Thank you very much. It's now my pleasure to introduce the second speaker for today's webinar. Brad Thompson is the co-founder of the Hallie Project, an organization established in 1999 by Brad and his wife Karen in response to the challenges they were and still are facing in raising their daughter Hallie. Today, Mr. Thompson will be discussing the Hallie Project parent-partner model, including the benefits and the roles of practices and families. So I'll turn it over to you, Mr. Thompson.
Thank you. I want to start by just saying I'm humbled to have the opportunity to speak with you out there today. And I can tell you that having a child with special needs certainly changed the trajectory of our life, our family's life. And even at 25, Hallie's presence in our home still has an impact on every decision that we make as a family. Next slide. I, like Dr. Earls, I don't have any relevant finances, period, much less financial relationships. But in the interest of full disclosure, I should probably tell you that picture on the slide previous has more hair than the person that's speaking to you today. So I thought I should probably tell you that. Next slide, please. A little history about the work that we are doing and have been doing for several years is that I had the privilege many years ago to serve on the AAP's Medical Home Project Advisory Committee, and being a part of that committee allowed me to get to sit with people like Dr. Antonelli and Dr. Cooley and Jeannie McAllister and Amy Gibson and Dr. Mann and on and on and on. And every time we would meet, we seemed to have this same recurring conversation, and that we would go around the room and kind of give updates on different things that we're doing. And I would talk about working in Dr. Sherry Medford's office in Amarillo, Texas. And at the end of my 2-minute spill about that, Dr. Antonelli would always raise his hand and say, if I had a Brad Thompson in my practice, I would do this too. To which I would respond, you do, you just haven't been looking through the right lens. And what I'm thrilled about is that today I'm talking with you because I was right. And you know, I often hear practices talking about including families, and a lot of times that inclusion looks like a practice improvement committee, something along those lines, which are great. But I want to encourage you that that if that's the way you're using families and patients in your practice, you're really just getting the tip of the iceberg of what they have to offer. We began working with families who have kids with special needs in 2000, and as a result of sort of a mutual frustration between trying to gain access to meet and help families and support families, and Dr. Medford's frustration of trying to connect her families to people who could help them, and them not following through, we created what's now a program, where I would show up at her office on Fridays, and she would schedule well-child visits for patients with special needs. And as she saw the patient, and when she was finished with medical conversation, she would ask them if they would like to talk with someone who could help them with other things, whether it be community resources or struggles in family relationships, extended family, struggles at school, whatever those struggles that fell outside the medical arena might be. And since 2007, so 8 years later, we've only had one parent who said no, they didn't want to talk to me. Well, so as we would continue to do that work and have those conversations, and people would invite us to different places to speak about the work that we were doing, Amy Gibson of former AAP fame and now at the Patient-Centered Primary Care Collaborative, and Dr. Tom Tonagis, who was at the time at the Boys Town Center for Child Health Improvement, gave us a chance to see if what I was saying was really right, if there were Brad Thompsons and practices all over the country. And so they scraped together some grant funding, and we were able to train partners in 6 practices. And I am thrilled to tell you that 8 years later, all 6 of those practices continue to have a parent partner, and they are all supported at close to full-time levels, either through their Parent Training Information Center or some funding through the practices themselves. And so we were excited to see that, yes, it did work. And over the 8 years, we've had opportunities to go in some other places, and now we have practices that are functioning with parent partners in the states of Wyoming and Montana as well. And one of the neat recent things that have happened is that our project was written into Montana's CSHCN budget, and so we've been blessed to get a little more permanent source of funding, at least in the state of Montana. Next slide, please. On this next slide, you'll see a bunch of words, and what I really, you can read those words later. What I really would like to draw attention to are those outcome measures that we're trying to measure. And you know, every place that we've been and done this work, the groups of people that we've talked to have all really liked the project. Families like it for obvious reasons. Providers like it because it allows them to be a little more efficient. It allows them to pass on conversations that they weren't really trained to have, nor are they able to bill for. And so all of those things are obviously good, and people like that. But those satisfaction measures are never going to move the bottom line necessarily. And in the current economic times that we function in, that's important, and we get that. And so we're looking and are in the process of measuring some other things that will have an impact on cost, like efficiency and other things that reduced hospital visits, ER visits, better treatment plan compliance, those kinds of things that that might move that bottom line to save systems some money. We recognize that kids with special health care needs are the frequent flyers and the high-cost people in every system. And so what can we do to maybe lower the cost of providing them the best possible service? Next slide, please. So our model is very simple, and we have some criteria for selecting providers. And if you're on this call today as a provider, you can probably check all those boxes. But probably the most important one is the fact that you understand the practical and emotional expertise that healthy and experienced family members can provide. Next slide. There are also some criteria for parent partners, of course. And the first one is that they need to have some experience in navigating systems. We see a lot parents of young children who are really excited about doing something to make a difference and trying to help others. And yet, if you haven't experienced the chronic nature of emotions, of going through a few cycles or seasons of life with your kids, your credibility is going to suffer a little bit. And so we want to make sure that they have some experience in this system and in this life. And so we want to make sure that they're healthy and balanced, and that they prioritize healthy advocacy in relationships, and that they're good at building those. And most importantly is that they mesh well with the clinic care team, because we're invading your space a little bit, and we want to make sure that we're of value added to the service you're providing our family. So, next slide, please. And I also want to, as we're switching slides, we just know that there are far too many advocacy approaches that almost encourage an adversarial approach, and we want to stress that this is about team building, because there are a lot of people that I and my wife Karen needed to have on our team to get Haley to where she is today and where she will go in the future. And so building partnerships really, really a fundamental importance to us. I have this slide there because I think these are questions that we need to ask, and that the project that we employ can help to answer. But what are the things that lead to caregiver burnout? You know, for caregivers, it's the chronic nature of need, and it's the dead ends and the mazes that we find ourselves in when we're trying to locate services or secure help. And there's also this to-do list that you can never find the bottom of. And so it can get easy to give up and to just survive if you don't have somebody who's been there and can tell you, we can do this. And a parent partner allows us to do that. For providers that I've talked to, and I would assume there's a common theme in there, it's the details that steal the focus from the medical issues, which drew you into this field to begin with. You wanted to help people have a higher quality of health, and so many times you end up having conversations about your child's IEP meeting that's coming up, or what do we do with the in-laws for Christmas holiday, or how do I deal with my husband who's still in denial about what's going on with our child. And so all of those things make it difficult to maintain efficiency and detract from the work that you really got into this business for. And so, and in all of those things, patients and family members are uniquely qualified to take some of that burden off of you, and in many cases can do it better, because a parent who's been through this process a few times not only knows where to call, but they know who to talk to inside that facility who is most likely to help. And they understand that emotional roller coaster because they're on it too. And they can be the listening ear that can cost you a lot of time in a room and make wait times longer for other families, and all of those things that you're doing because you want to provide them answers to all the questions. The benefits to families, next slide please, are are pretty apparent, I think. It gives them someone who's been there. It gives them someone they can talk to away from the doctor's office. Once we have a relationship established, there's plenty of time and space in my week for a parent to just call me directly for issues that don't have anything to do with their child's medical condition. And it not only gives them the where, but the who that I mentioned before. And next slide, please. The benefits to providers, I think, are equally rich. And one of them is the reducing the cost of that listening ear that I talked about. It allows providers to spend more time at the top of their license. You get to do the things that you went to school for. And it always leads me to the questions, what are the things that you do regularly as doctors that are time-consuming and not reimbursable? And then taking that one step further, how many of those things could you give to a parent partner who has experienced them personally, can give support because they've been through that issue more than one time, and can allow you to go to the next room to treat the next patient? And so those are things that just I think are of huge benefit to providers, and things that providers have told me are really helpful from our program. Okay, so next slide. Just a little bit about how the project works. We have written and teach a 3-day initial training program where we talk about things like understanding the chronic nature of grief for families who have kids with special needs, and where those chronic needs and chronic emotions may come up. Things like changes of season of life, or change in a diagnosis, or moving from one school to another. Those are things that will trigger a grief response that says, basically, this is not the life I was expecting or hoping for or planning for. We talk about how to equip parents to be the coaches of their child's team, that we may start off leading them and helping them connect to resources, but ultimately for any child to be in a place that allows them to reach their potential, moms and dads are going to have to step up and take the lead, because we're the ones who dreamed for our kids. And so we talk about those things. We talk about how to navigate the office environment. We talk about HIPAA. We also talk about our role and what our role is not in a practice, that we are not there to give a second medical opinion. We're not there to critique a doctor's bedside manner. We are there to support and further their mission of providing the best comprehensive family-centered care that we can. Then after the initial training, and as we start working in practices, and we have a monthly group call that I lead for them, and it contains continued training. A lot of times we'll use cases of families that partners are actually working for, obviously protecting their identity and all of that, but to bring up things that come up that are pretty common in most practices. And then we also talk about data collection as well. And then we have a monthly one-on-one call, because one of the concerns as we started this project was, how do we make sure that we keep our parent partners healthy? Because not only are they doing this work, working with families who have, in many cases, high levels of need, but these are parents who have children with special needs themselves. And so how do we make sure that they're balancing that in such a way that they stay healthy going through the process? Next slide, please. We are evaluating, and if Dr. Mann's on the call, every time I see her or talk to her, she's beating this drum for me, and we want to do it because we truly believe that it needs to be measured, and if it's doing what we think it's doing, then the evaluation will support that. If it's not, then it becomes one of those good projects that we know helps families, but maybe it's more of a thing that you have if you can afford it, and not something that's as essential. So we're wanting to measure that. Our first evaluation was done by Dr. Sharon Homan, and it was satisfaction survey funded by the Mountain States Regional Genetics Collaborative. And those returns were very positive. And what it led to is a desire to say, okay, everybody involved and engaged in the system says it's a good thing. Now we need to measure to see if it makes a difference for funders, whether they be private insurance companies or Medicaid offices or whatever it might be. And so we are now engaged in that evaluation, and we've collected some baseline data, and we will be collecting a comparative sample end of June, beginning of July of 2015. So that's kind of all of that. And what we're really trying to measure is to see if there are improvements in things like health literacy, if there are improvements in parents doing those things that keep their children out of hospitals and ERs. So next slide, please. So we're hoping that comes back to be positive. Our funding in Montana has now been written into the CSHCN budget of their state program. And I love this quote from Denise Higgins, who is the bureau chief of that plan. And she says, the Parent Partner Program is an inexpensive solution to support families and provide assistance in navigation for support services. And that's what this is about. And we've also received funding from the Mountain States Genetics Collaborative and the Genetic Alliance. And we've been thankful that they've given us the opportunity to get into practices, give them a no-risk trial period to see how it works and if it works. And we've been blessed at every stop that the outcomes have been good, and the practices have wanted to continue that work. So that's it for me. Thank you for being a part of this, and we will leave a few minutes for questions if you have some.
Thank you very much, Mr. Thompson and Dr. Earls, for your excellent presentations. And we have had a number of questions come in submitted by the audience members, and I just want to encourage you to continue to send those for either Dr. Earls, Mr. Thompson, or both, and you post those in the question box window. So I would like to sort of move first to a question or two that came up for you, Dr. Earls, from the audience, specifically related to the community mixers. There were several questions that were interested in, that were specifically looking for some more information on that. Can you speak briefly about how you encourage or incentivize people to attend those community mixers, and a bit about how many on average of the different type of professionals actually attend those meetings in the different communities?
Sure. We've had experience primarily with mental health at this point and oral health, as I pointed out, and we've really not had to incentivize folks very much. I think when you get down to it, people are frustrated around these issues of communication and referral and hearing back and so on. I think for one of our dental mixers, the local hospital put out a little buffet dinner for the pediatricians and the family docs and the dentists, and I think we had, this is one county, I think we had about 30 attendees to that, dentists and pediatricians, which was fascinating. The pediatricians were afraid to refer because they thought they were over-referring to the dentist, and the dentist said, please send us these kids. We'd like to see them before they have terrible things in their mouths. The mental health ones have been pretty large in several of our networks. Again, community mental health folks really wanting to be able to communicate with the primary care docs. The primary care docs being very frustrated about how to get information back. So again, we've sometimes had folks that have donated food so to get people together and talk, but we've not had to do major incentives. But we've had really good attendance in those areas. And I think part of the secret is the issues bubbled up from the community itself. And our role was to try to facilitate and get people to a common place.
Thank you. And Mr. Thompson, this is for you regarding some of your comments on evaluation. Can you expand a little bit on what is being evaluated and a little bit perhaps on how the information that's obtained is being used, if so, to make changes in the model?
Yes, we're collecting the baseline data with interviews with our partners and the families who are in the different clinics, and what we're trying to measure are things such as health literacy, like I mentioned. Do families understand what the doctors are trying to do to help them? We're trying to measure how they receive care. Are they coming to their primary care place first, even if it's evenings and weekends? Are they starting there, or are they accessing the higher cost places of care? And then those are the big things. And then we will, from the comparative data that we'll collect beginning in June and July, we will look at that and then make changes based on what we're seeing in comparison. Another thing that we're doing as a result of that data is that some of the doctors who are participating in the project are seeing things that they would like to have measured, that in the second iteration of the instrument we will include those questions and try to measure those things as well.
Thank you. And Dr. Earls, can you speak briefly about what outcomes for the pediatric population you've seen with the work with the CCNC?
Well, they've been pretty significant. Over time, CCNC has had a big impact on hospitalization and ED utilization, for instance, on kids with asthma, although that really predates some of our CHIPRA activities, our more recent activities. Several things. As we have been able to have kids who come into foster care be enrolled with a Medicaid network, with one of our networks, rather than just enrolled in Medicaid, those kids, we've seen their cost per member per month be as much as $500 in difference, so in terms of cost savings. But we've also seen increase in the rates of those kids getting their EPSDT visits. So that's been very positive. In terms of our work with quality improvement specialists and developmental screening, we've not only seen really excellent rates of developmental screening. We have really high rates in North Carolina, close to about 80% of the time kids are getting their developmental screens when they're supposed to. But we're also seeing improvement in people making referrals and receiving information back. We still have a long way to go. In our adolescent work, we've seen increase in annual visits for adolescents, yet we still have a long way to go. So we have quality measures that we, as I mentioned, share with practices based on claims quarterly. And then we've done additional help with practices in pulling data. So, so we've seen a lot of positive moves. We've seen a particular increase in people documenting that they're referring kids to a dental home and then documenting what the dental home is. We've seen pretty significant increases in our rates of dental varnishing for young children. So it's been really wonderful to be able to do some levels of practice support and get those things to move.
Thank you. Now a question for you, Ms. Thompson, and several questions have come in related to, I guess you could say, the cost or the expenses of the program. So are the parent partners generally volunteers, or are they clinic staff? And if you could speak briefly, if there is funding required, say, for them, if you had any suggestions as to where others might be able to find some funding to support parent partners in practices.
Yes, no, the partners are paid. because the work they're doing is valuable, and there's also a commitment. You know, it's too easy to kind of say I have other things going as a volunteer, that when you have a job and you're being paid to do that job, you're a little more committed and can be more easily counted on. The partners are chosen by the practice themselves, and then we take whoever they choose and we train them. And like I said, we have received funding from grants of all types, from NCHB. I think it's D70 grants that the states have used to fund our work. In Wyoming, they're looking at including this work in the Any Child Can project that they're working on. Like I said, in Montana, they've included it in the CSHCN budget. For the most part, though, they're started with small grants from one of those quality improvement or practice improvement projects, and then a few practices kind of rise up out of that and say, we would like to try this to see how it works. And so in Montana and Wyoming, our partners work 16 hours a week, pay them $15 an hour, and they're sole proprietors or private contractors as far as that goes. And then the cost of training and support is how I continue my work, and the initial training is $3,000, and then the monthly support is $100 an hour for the group call and for the number of parent partners that you have. So I think the number, and I should have this in front of me, but to operate parent partners at that level in 4 practices, the cost is in the $40,000 to $50,000 range for a year.
Thank you. And one final question. We have just a couple of minutes left for you, Dr. Earls. Can one attendee asked if you could speak just briefly on how you see the role of the families and the patients in the efforts that you've described?
That's a great question, and I'm fascinated in listening to how Brad has been able to build a program and cobble together funding to get that going. Our work with the practices, particularly the ones that have worked specifically on medical home, has been to try to help practices involve families at a couple of levels. We've been using the Family Medical Home Index for them to understand internally at the child and family level, how are you doing with being family-centered, but also trying to make sure that we have family members involved from the get-go in initiatives and encouraging practices to have family members on their quality improvement teams with more or less success. And a lot of it being around this previous discussion is, paying people for their valuable work and figuring out ways for primary care to do that.
Thank you. Well, I want to thank you so much for your questions from the audience, and thank you again to today's speakers. We appreciate your time, sharing your experiences and your expertise with the audience today. This webinar series was presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau of the Health Resources and Services Administration. The National Center for Medical Home Implementation houses a number of care coordination resources on their website and on the sites of their partners. These resources include clinical guidance, tools, videos, a comprehensive curriculum, and a measurement tool. Visit the links on your screen for more information, and please don't hesitate to contact the National Center for individual technical assistance. So the webinar recording, slides, and some of the unanswered questions will be archived for about a week from today on the National Center website. Additionally, you'll receive an email asking you to complete an evaluation. It will only take a few minutes of your time. If you're in a room with your colleagues, we also ask that you please do access the evaluation and let us know how many participated. So this webinar was the second offering in the 2015 webinar series, the third and final webinar in this series, as you see on the slide, Beyond Implementation, Capturing the Value of Care Coordination, will take place on May 28th. We encourage you to register and follow the link on your screen to do so. So thank you very much, and I appreciate everybody's attendance on today's call.